Okay, we're
Okay,
on.
I think we're
Yeah.
on. We just did an entire intro and realized that we were not filming. So I think we're live now. I'm in contact with my team and just waiting confirmation, but it looks like we are on now. So let's get started. Welcome. You are on Facebook Live with Asian American Justice and Innovation Lab, or AGILE for short. I'm Dr. Sandra Sohee Chi Kim, founder and executive director of AGILE and adjunct professor of race and ethnic studies at Cal State LA. And I hope you're feeling well and not too isolated. Thank you so much for joining this conversation. We are here today to talk about the current pandemic crisis from the perspective of social justice issues. And our guest today is someone very special to me, Dr. Scott Kim, an infectious diseases specialist and community health expert. And you may be wondering why we are sitting so close to each other. This is not proper social distancing practices. He is my husband, and I'm very, very excited to have him on Agile's platform to talk about a really important topic. Welcome, Scott.
Thanks.
Before we start, as we chat, feel free to leave any questions you have for Dr. Kim in the comments section, and we will get to as many of them as possible during the Q&A. Please state where you're commenting from, where you're watching from. Please state that in the comment. Thank you. So thank you for taking the time to do this.
Yeah, sure. My pleasure.
Did you want to say anything in greeting our audience?
I guess just off the cuff, I do want to say that I recognize that this is a very frightening time for people, and people are getting conflicting information, lots of information, overwhelming amounts of information from a lot of people. I definitely want to offer you any insights I have from my experience as a doctor and someone who manages, with a good leadership team, a healthcare organization that is in the community, taking care of people who are sick or concerned about illness. I would not, by any means, introduce myself as a foremost authority on public health, or what is best for our government to pursue in the way of legislation or public health procedure, even though I do have opinions about it. But I present myself to you guys as a peer, as someone who is also suffering the ramifications of this epidemic, and I'm just grateful to be part of the conversation.
Great, thanks. So what has it been like for you taking care of patients during this time?
I'll say that this has been the most challenging time in my career. Definitely, when I weigh the suffering of my patients, of my peers, of my providers, I have to admit it's been overwhelming. I've had difficulty keeping well. I've had difficulty sleeping at night. I've had difficulty maintaining a day-to-day sense of mindfulness. And for those of you who know me, my ability to meditate and stay mindful and aware of what is important is so critical to me. But like many of you, I've felt sucked up in this vacuum of constant 24/7 news and panic. So I've had to extend compassion to myself as well as to others. A lot of doctors and providers don't naturally do that. For those of you who are in healthcare professions, I encourage you to be mindful of yourself and show compassion to yourself. Social distancing and shutdowns and lockdowns of workplaces often don't apply to us as healthcare professionals. Certainly, it's not applying to us now, but that does not mean that we can't and shouldn't take time to tend to ourselves and our emotional needs in these very challenging times. Yeah.
In terms of taking care of patients in your clinic, do you see any disparities coming from socioeconomic status or marginalized groups?
You know, I don't take care of a lot of rich patients, so I can't really speak um, to the full range of disparities and how those are impacting access to healthcare and the wellness of our patients. In my practice environment, I mostly take care of Medicaid patients, some undocumented immigrants, a lot of poor working people. And even before this pandemic, I think times were very challenging for them. Most of my patients um, have to weigh a lot of competing priorities from day to day. Their healthcare needs are just one small part of the intricate and very difficult balance of priorities and imminent concerns that they have to juggle. They have to put food on the table. Whether they're sick or not, they have to go to work every day. It's very difficult for them to come see me during working hours. And frequently, they will not show up for their appointments if their boss says, you know what, I gave you that hour to go to see your doctor, but we're busy today, so I'm sorry, you're just going to not have to go. So my patients are used to putting themselves and their health last in the pecking order of priorities. And unfortunately, I still see that now. I'll describe for you two patients that I saw just 2 days ago on Thursday in clinic. One was a relatively young patient, recently unemployed, who has all the time in the world to be on Facebook and social media and in the internet looking at the news. And even though she was not sick, she was coming to clinic because she was deathly afraid of being infected or being at risk of infection from COVID. So really, she was just coming to get tested for the virus. Another patient who came in just an hour later was visibly ill with a respiratory infection. She was a monolingual Spanish-speaking patient who had her young son with her, since obviously school is out. And her main concern was that her employer had forced her to come see me because he was uncomfortable with the fact that she had a runny nose and a cough. For her, the idea of COVID was just so dramatically different from the idea held by my previous patient. She wanted clearance to return to work. She had been advised to wear a mask in the clinic, but was not wearing it when she saw me. I advised her actually a couple times during the visit to put her mask on, for her safety and for mine. But I could see during the conversation that her interest was to get cleared to go back to work as soon as possible. And I totally get that. Our patients, like our community, are in totally different places when it comes to this epidemic. And frankly, for a lot of the working poor patients that I see every day, the risk of death from a respiratory virus is maybe real, but no less real than the risk of not being able to go to work, pay the bills, put food on the table, take care of the children, and by the way, the chronically ill elderly adults in the home that are counting on your ability to bring home a paycheck. In many ways, I think those economic concerns are more imminent and existential because they're much realer, much more real for our patients than the risk of getting an infection from somebody. And unfortunately, what that means for some of them is that even though they may have mild symptoms and may be at risk of passing the disease to others, they're going to take that step of going to work for as long as they can, doing what they can to keep their household alive. In some circles, we would call that perverse incentives, but that's really how our economic system unfortunately works and how it worked even before this pandemic began.
Speaking of testing, COVID-19 testing efforts in this country have been both limited and often defective. And so what should we do about testing at this point? Do you recommend people who are feeling a little bit sick, have a runny nose, like the patient that you're describing, go get tested? Or at this point, is that the wrong move?
It's a really difficult question. I'll say that a lot of this goes back to the resources that have been made available to us in the community, um, by the federal government and the state government agencies who are looking out for the public health of the nation. And I want to extend compassion to our national political leaders. They have gotten a heck of a lot of criticism for what they have done and haven't done. But let's acknowledge here that what we're facing here as a nation and as a world is absolutely unprecedented. I think anybody can point fingers at anyone about what has or hasn't been done. But in moments when I'm able to be mindful and aware, I recognize our leaders require compassion too. They're not making the decisions that they're making in order to hurt people or put people at risk. They're doing their best to handle the many competing priorities that they face, just like our working patients, the working poor that I spend my time in clinic with. I think that looking back, we have to admit February was a lost month for this country. We had our first confirmed case in the United States in late January. I think it was January 20th or 21st. Community spread was not established at that point, but we had every reason to believe that people were probably getting infected through international contacts and travelers. And we had an opportunity, I think, at that point to scale up testing, really to do contact investigations and isolate in a very strategic way in order to potentially contain the infection. We're in a much different situation now in mid-March where obviously containment is impossible. I don't know if they're using these terms now, but I think the CDC, many at the CDC would admit community spread in all states is definitely happening. And at this point, whether you've had international travel or not is almost irrelevant. I think if you're having cold or lower respiratory infection symptoms, it's certainly possible that you have COVID infection at this point. So that's the scary reality. And within this new phase of the American epidemic, testing has a much different role, a much different importance than it might have had 6 or 7 weeks ago. We have to test now not for the purpose of containing epidemic. We have to test now to determine whether patients at high risk of complication will need to be referred for care earlier and perhaps started on investigational treatments much earlier than they would otherwise. So testing, I think, at this point is part of triage, much different than testing would have been 6 weeks ago when testing was about controlling or limiting spread of infection. Testing, as many of us have heard, is a very limited resource. And I think even with our government's best efforts, drive-through testing for anyone will probably not be available for the foreseeable future. And so we may have to start rationing tests and really using those tests strategically to identify people who could die of this infection. So in short, I don't have a very specific sense of how we should deploy testing now, because I'm actually not sure where we are in our supply of testing or how quickly our commercial labs and public health labs are able to process these specimens in relation to the sheer demand of inbound tests. We have yet to see, but at some point I believe we're going to have to ration testing and devote it very strategically in order to save lives. Yeah.
I don't know if you're allowed to comment on this, but where you're working in a community health clinic, how are you dealing with this testing issue on the ground right now? Are you experiencing shortage of testing kits and defective testing kits? Do you have to turn away patients who want to be tested?
Yeah, definitely. We have a lot of patients lining up and calling in to be tested, just like the patient I mentioned. And because we're at the front lines, and because we do um, healthcare in a setting where there aren't a lot of agencies who have their doors open to poor working patients like our patient population, there's a lot of pressure on us to offer testing and to offer, beyond that, education and guidance to our patients about this pandemic and what they can do to help themselves. We are making testing available. Our approach is to be very mindful of the limited resources of our community partners and the laboratories that we're leaning on. So we're obviously following very closely the policies and the guidelines that have been published by the LA County Department of Public Health and the CDC. I'll comment more broadly and say that we're in a phase of the epidemic right now where healthcare centers and hospitals are not yet overwhelmed, but definitely seeing a rapidly increasing number of cases that are concerning for COVID, and actually some very, very severely ill patients with probable COVID infection. And this is a very critical phase in the epidemic. What I'm concerned about is that what the United States will see on account of its approach to the COVID epidemic is a disparity in health outcomes according to socioeconomic status. I haven't seen any data on this coming out of other countries, but I'm worried that we will soon experience this in the United States. Right now, I think in the relatively early phase of the epidemic, I don't think that the limited supply of hospital beds, ventilators, testing kits, or other technologies are what will differentiate clinical outcomes among poor versus well-resourced and well-insured individuals. But I do think what well-resourced hospitals and health plans have to offer that organizations like mine don't is people resources. Well-resourced health plans and hospitals have staff who can receive calls from concerned patients, nurses who can actively triage patients and even arrange for direct admission to hospitals, providers who can be on the phone and available in person to prescribe treatment or facilitate the referrals and admissions needed for those patients who have chronic illness and are at high risk of infection. Those are people resources that community health centers don't have. And ultimately, what I'm worried about is that what we'll see as the epidemic progresses is that people who are poor, less well insured, don't have these premium health insurance plans will take longer to access care and will not get into hospitals and ICUs as quickly as those who don't. And so on top of seeing an escalating case fatality rate, what we may end up seeing is poorer health outcomes in poorer people. Now, what really concerns me about that is that we've had evidence, I think, for a long time demonstrating that there are disparities in health outcomes among poor people. But when it comes to a pandemic like this, that's extraordinarily frightening and deadly, I think that the public outcry, if there is indeed concrete evidence of disparities in health outcomes according to payer status or socioeconomic status, that outcry could be the precipitant of major policy change in healthcare policy. And what I mean by that right now is that I think in our current healthcare system, we allow for what I described as perverse incentives. We allow for people not to opt in for insurance. We allow people to choose work over necessary preventative care. We allow people to fall into desperate poverty and make choices that are bad for them and for their families, ultimately, because of the imminent need to put food on the table. And when it comes to a pandemic like this, those perverse incentives will cost people their lives. Mm-hmm. And I think the moral indignation that will come out of this evidence that poorer people are dying at a faster rate may be very much, I think, the spark of a wholesale change in our healthcare system, a change that's actually needed to protect us better as a society, and ultimately to lower the healthcare costs to the system. As you can imagine, if someone has an incentive to avoid preventative primary care in order to work, and they put off care for a long time, ultimately costs to the system that they will incur when they end up on dialysis or end up in an ICU or end up requiring an organ transplant is absolutely considerable. We've needed to move, I think, toward a single payer system for a long, long time, or at least a system much more regulated, quality driven, and accessible to everyone, regardless of their means. But it's very possible that the consequences of this pandemic will force us to that decision point. And all of a sudden, a year and a half from now, Medicare for all doesn't look like a pie in the sky idea. It looks like what's necessary to keep the populace safe and to keep people at risk of infection from putting others at risk. So, it's a very critical time. It's a very scary time, but it may be very much, I think, the kindling necessary for creating that spark for broader social change that's needed to make this nation healthier and more robust over the long term.
Mm-hmm. So, on that note, what do you think, or what do you predict will be the short-term and long-term impacts of this pandemic on our country?
Yeah. Well, I can't stop thinking about the human impact at a daily level. I don't know if you all have experienced this. Certainly, as an infectious disease doc, COVID was a very imminent personal concern for me as soon as I learned about it in December, moving into January. And as you'll recall, in mid-January, I shared my anxieties with you, and I told you I think quarantine, school closures, disruption of society is going to happen. And I actually documented all my concerns in late January. I think that a time like this, a pandemic like this, unfortunately forces us to look at other human beings as adversaries. And that's what's really sad about this. I think in the short term, doctors are going to look at patients as threats to their health. Patients are going to look at doctors and other patients as imminent threats to their health. Family members, we're going to get to a point where family members are going to look at other family members as imminent risks to their safety. And this overall adversarial approach to human relationship is fueled by public policy around quarantines and home isolation, but for better or worse is what is necessary to actually implement social distancing and quarantines and lockdowns. We need, as a nation, to look at one another as imminent threats to our health and well-being. But it's very sad. One thing I enjoy about being a doctor is being physically present with somebody, having a deep, potentially transformational conversation with somebody who is afraid to die or afraid to be sick, and wants to have a deep and human conversation with me about how to stay well. When I'm masked and my patient is masked, the signals change entirely. The nonverbal signals change entirely. I'm not shaking hands. I'm not giving hugs. And I know my patients notice it. I feel that. I feel that pain of human separation. I was telling my providers, my nurse practitioners and physician assistants and physicians in a departmental meeting yesterday that if this is what primary care medicine would look like every day for the rest of my life, I would have to stop doing it, because the joy for me is human connection. And in these days and times, human connection is being sabotaged. for the best of reasons and for the worst of reasons. I think, as we move into the later portions of the pandemic and hopefully look forward to normalization of social relations, I think we'll move from seeing the extremes of a human feeling, compassion on the one hand and hatred and fear on the other, to more of interestingly, I think what I would call like a benign neglect. When it's actually safe for us to congregate again, I think it will be weird. I think that we'll recognize that we've become so unused to having just daily normal social interactions with people that the idea of sharing a public space with someone, even when it's safe, will be strange. And I think actually that's going to be a wonderful thing when it happens, because we won't take it for granted. I think we'll be able to rediscover what it means to be part of a community. I would call it an awakening. We're going to awaken to one another again. When we're able to congregate in restaurants, in churches, in movie theaters, I think we'll just recognize, wow, we took something about this so for granted for so many years. And this ability to just share a space with someone is precious. It's an awakening to presence. It's an awakening to society and what it could mean. I really hope that that's the genesis of deeper cultural change. That goes beyond policy and law, but gets to the very root of how we choose to take care of one another and how we choose to engage in community. I am worried, I think, at a geopolitical level about the long-term impacts of this pandemic crisis. And like I previously discussed with you, I'm worried about how this could fuel nationalism, how it could fuel obstacles to globalization and free interaction and trade among the nations. Those forces were already at work before this pandemic struck. And now that many nations have essentially stopped interacting with one another, it will be difficult to create, I think, a spirit of international cooperation again. I worry about a strong geopolitical backlash against China. And I worry about the ramifications that could have for the way Asian Americans are treated in this country. For many years, I actually worried that if North Korea ever created a major incident or even declared war on the United States, that a lot of Asians, not just Koreans, would be targeted and marginalized in society for that. So every time there was unrest around, North Korea's actions or policies, I actually feared for us as a family. And I think my fears around that are very much in play with regard to this pandemic. I think that sooner or later, we're going to have to reckon with the backlash that is sure to come against China and against Asians in general. I worry about that, and I see that in the near future. And I just basically what I've shared is I think there will be competing forces that will shape and determine our culture in the next year or two at a very human individual level, a longing for interaction and to appreciate the presence of other people and the importance of community. And then on the other hand, this very egoic national sentiment of preserving self and confronting or even resisting others. Yeah.
Should we take some questions from our audience first?
Yeah, absolutely.
Okay. Let's see here.
We're getting some questions in the chat here too, right?
Yeah, Jean is actually copying and pasting them and texting them to me, cool. So we can see it right here. So just a few technical questions. Michael Manalo asks, so you said we are now at a point, if you have respiratory difficulty, you may have COVID-19. Is that correct?
Yeah.
Okay, and he also wanted to clarify, is testing only done at labs? We don't have any in-home testing in LA County, correct?
I think that there's in-home testing available in some countries. There's been opportunity for a lot of labs to innovate, and there's no reason why we can't develop an in-home test. It's just not available in the United States right now. So yeah, we are limited to the commercial and public health and CDC laboratories, which means that testing is conducted by a swab by a healthcare professional that is sent out for processing at a lab. The turnaround can be anywhere from 2 to 3 days. But yeah, there will probably be some new innovative ways to get testing for the general public. There are already drive-through testing centers in some cities, but that's not universally available right now. So yeah, that's what we've got to work with for the time being.
Okay. Noel Jung asks, for someone who has a history of respiratory issues such as bronchitis or walking pneumonia, what's some advice for people who are more susceptible for respiratory illness? What are some things we should know?
Yeah, I think that healthcare professionals have in various countries identified chronic illnesses and other health risk factors that seem to be more highly associated, not just with symptomatic infection, but with death. Cardiovascular disease, diabetes, and high blood pressure seem to be among the top three, but I'm sure asthma and COPD are up there as well. My advice for anyone with these conditions would be consistent with what we're hearing from the CDC, which is absolutely home isolation, social distancing, and just maintaining the natural infection control measures that you would use if you assume that any public environment has circulating pathogen. So wash your hands constantly. Assume everything you touch, whether it comes to whether it's a doorknob, whether it's the mail, whether it's
Cash, right?
even cash. Yeah, assume the hand is dirty before touching yourself, and wash your hands with soap. Isolation and infection control are going to be the keys, I think, to keeping everyone healthy for as long as possible. Healthy for as long as possible. And hopefully long enough to make it to either functioning therapy or a vaccine down the line.
How long do you think it will take to get a vaccine up and running?
Yeah, very unpredictable. I think best case scenario is within 6 to 12 months. So best case scenario could look like we have some vaccine available at the beginning of the next flu season, so that we are vaccinating not only for influenza but for the predominant strain of COVID. Obviously, a vaccine is only as good as it's able to stimulate a neutralizing antibody response against the critical portions of the virus's replicative mechanisms. So if the antibody targets the virus but doesn't prevent cell entry of the virus, it's not effective. If the virus has already mutated to the point where the original strain that was used for the vaccine is irrelevant, the vaccine won't work. So even when we have a vaccine that appears functional in vitro, there's no guarantee that it will work for the populace in preventing disease. Those are the many challenges facing the vaccines. I'm sure we'll have many iterations of a COVID vaccine moving through the next year and a half to 2 years. But I'm hopeful we'll have something, at least something by next flu season, because it's probable that COVID will begin seasonal spread, just like influenza. Yeah.
A couple of people are asking about how likely it is that the virus has mutated since it's been in the United States, or what's the rate of a virus's mutation?
Yeah, varies by virus, but you can count on mutation. Absolutely, it's just part of the replicative reality of viruses. Looking back at HIV, for instance, HIV almost has mutation built in to its replicative process. It's what's made developing a vaccine impossible. COVID, I think, already has demonstrated some evidence of mutation. And the question will be, to what degree those mutations allow the virus to escape the natural mechanisms of human immunity, and to what degree those mutations will make it difficult for us to find a what we call conserved target for an antibody response that we would provoke with a vaccine. So those are unanswered questions, and I don't know, but you can count on mutation happening at some level with this virus.
And that's what makes finding the vaccine challenging, right?
That's right.
Okay.
That's right.
Let's see. Raymond Liu asks, how can API standing for Asian Pacific Islander American organizations, help their local communities against social injustices and discrimination? Do you have a perspective on that from the medical side?
Yeah, I think I have less of a perspective from the medical side and more of a perspective just at a basic human level.
Mm-hmm.
I think we have to be so careful about the messaging and terminology we use around this infection. In my journey of mindfulness, I've learned to forgive, as I mentioned before, people that I had no right to be angry against because I don't know them and I'm not present with them. And this includes some of our leaders, political leaders at the national level. I've learned to have compassion for them. I've learned to recognize that I don't know who they are because I'm not present with them. But I do believe, regardless of our efforts at respect and compassion, there is a role for accountability, and there is a role for calling out terminology and messaging that is cruel and designed to divide people and punish people unfairly. And I think calling this virus a China virus or a Chinese virus is galling, insulting, deeply prejudicial, and cruel all at the same time. We have to, in our various community advocacy efforts and social justice efforts, be very aware of the terminology and the imagery that's being put out there in the media and by our public representatives, and we have to hold them accountable for that. Italy just surpassed China in mortality from this illness. Are we going to call this the Italian virus or the Italian epidemic? Are we going to start branding Italians as being the cause of the world's greatest tragedy or some instrumental role in that? You can all see how ridiculous that would be. But I think, our role, I think, as citizens and participants in community is to be mindful of language and to protect one another with the language that we use around illness and around public safety.
Great. Toshi Solansky asks, has there been a thought that this was not really novel, but something that was never tested for those who died with pneumonia in the past and was just categorized as pneumonia as the cause of death in previous years? What's the explanation for why someone who has never been associated with any of the probable carriers or vectors to be positive with COVID-19?
Yeah, that's a great question. And I can't give a definitive answer to that. I would say most scientists do not believe that this has been part of the ubiquitous coronavirus spectrum that people are exposed to season to season. The reason that we think this is a novel zoonosis, a novel virus, is the exponential rate of spread. If this is a virus that human beings had been living with for years, if not decades, we would have some herd immunity that would, by definition, be slowing the rate of spread because the R naught of this virus would be much lower. We do not seem to, as a human society, have significant herd immunity, latent immunity against this virus, and that's the reason why the rate of infection and symptomatic infection, at least, is really spiraling at an alarming rate. I think that we have seen asymptomatic infection. Asymptomatic infection is probably the most common form of this infection, and that is probably that's probably the best reason we have for the people who test positive without symptoms. Not that they've been chronically infected, but that they were recently infected as a result of this pandemic, and were able to tolerate the infection and avoid inflammation as part of their response to it.
Charlene Choi asks, there seems to be differing populations in terms of age, gender, etc., becoming sick and critical in countries around the world. Do we know anything about what is causing these differences in outcomes in each country?
I think definitely the medical evidence to this point demonstrates that older people and people with chronic illness are having a much harder time with the virus. And though we don't have a specific explanation for that yet, there are a lot of good reasons why this should be. Younger people, particularly children, have immune systems that are much more adaptable and agile than people who are much older and people who have chronic illnesses. I think that children are able to tolerate infection with less inflammation, and they're also able to clear infection more quickly because of a rapid and highly effective antibody immune response. Older people, by contrast, do not tolerate infection very well without exuberant inflammation, and they clear virus more slowly because their antibody slash humoral response is really just not as adaptive and agile. So you have this terrible combination in elderly people of longer and more progressive viral infection and worse inflammatory symptoms in response to that infection. I think it's too early to tell whether there are true differences at a biological level between ethnic groups and races. I certainly haven't seen any compelling evidence to this effect. The mortality slash case fatality rate in Italy is extremely alarming, but the predominant explanation for this is that the epidemic spread extraordinarily quickly there, and the case fatality rate for Italians was very much determined by the limited supply of ICU resources necessary to take care of them in the advanced stages of the infection. It's certainly possible that there are genetic variations in for example, the predominance of the receptor at the cellular level that the virus uses to enter the body. We think that the virus enters enters body cells through the use of a specific receptor called ACE2, and there may be genetic or even ethnic group variations in the density of this receptor on certain body cells, but that's all theoretical right now. It does not seem like any country, ethnic group, or race is being spared in this pandemic, and certainly people of all races and colors are dying of it right now.
I've also read that in Italy, the population skews older, which is also a reason for why there is a higher fatality rate there. So Danley asks, there are some people who argue that the economic, social costs to our current strategy are too great and that there may be more targeted ways to contain this. How would you respond?
Yeah, Dan, I love this question because, this is really why we pay politicians and public health officials the big bucks. They have to make the unpopular decisions at the end of the day, and they're going to. I think they're going to have to make very difficult decisions. Right now, the very difficult line that our public officials are trying to toe is, on the one hand, the need to make people feel safe, and on the other hand, the need to devote healthcare resources to the areas where they are really needed. So let's take, I think, one extreme of this scenario. If we determine that, you know what, we can't keep everyone from being infected. And in fact, we have no right to assure the American public that there's any way we can decrease, in general, their risk of infection. We're gonna have to concede that infection is going to be ubiquitous and almost everyone is going to be exposed. If you're able to establish that foundation, then you have a rationale for saying we're going to reserve testing and we're going to reserve higher level care, specifically for those who are at high risk of death from this infection, acknowledging that many people will get very seriously ill, many people will get symptomatic, but they won't die. Now, that is not part of the fabric of American culture. We have some of the most entitled healthcare consumers in the world. And definitely, I think it would be very hard for the CDC and the US government to take this stance of determining that the general public is going to be infected and we're going to limit our use of extreme measures to those who are at highest risk of death. So it's a great question, and it's going to turn into a political one very soon. But the fact of the matter is, we do have limited healthcare resources. We are going to have to ration them in this time of epidemic if the projections on incidence do bear out. So there are tough times ahead.
Okay. So a couple of technical questions. D. Smith asks, can an asymptomatic person spread COVID? And Julie Trong asks, there's news saying that type O's have less chance of contracting COVID-19, while type A's have higher probability. Why is that? And what are some precautions to keep in mind before donating blood? Have you run across that?
Yeah, I don't know anything. I'll have to be candid. I don't know anything about the potential modulating effect of blood type or red blood cell antigens. From what I understand of the disease's biology, the pathogenic effects are really most concerning in the lung, and the endothelial cells of the lung. Red blood cells, from what I've read, don't seem to have a pivotal or central role in the multiplication of infection. But I'm sure our scientists are looking at every possible association right now. The other question was whether an asymptomatic person can spread COVID. I think the balance of information we have absolutely indicates that not only is this possible, but could be the main mode of transmission. I mean, when we look at the exponential rate of spread, I think we have to account for the distinct possibility that people with virus who are tolerating infection without inflammation are still putting infection into the environment through their body fluids. And so I would say I think there's enough evidence to suggest that spread from asymptomatic individuals is happening. And that's additionally what makes containment difficult, if not impossible, at this point. And part of why, for better or worse, we must look at all individuals, whether they seem ill or not, as potential threats during this time of pandemic.
I'm just scrolling back up to see if I missed any questions. Thank you very much, by the way, for joining us and asking these very helpful questions. Charlene Choi also asked, do you have any thoughts on how we care for our nonprofit workforce in this difficult economic time? And I think that also points to maybe what this pandemic and panic reveals about the limitations of our social infrastructures in general.
Just a few months ago, we heard Andrew Yang talk about the universal basic income, which I feel is very much aligned with Bernie Sanders' view of, creating social safety nets and basic services for all American citizens. It's funny, right? Because maybe 4 or 5 months ago, those seemed like extreme measures that were designed to create a socialist state. And yet, when you look at what the American government is putting together right now in its fiscal relief package, what is it? It's a universal basic income, and it's guaranteed free health service for everybody who needs it. Pretty ironic, right? All of a sudden, we're doing the kinds of things that Andrew and Bernie were advocating for. What's changed? What's changed is that now, among the list of competing priorities, politicians in the United States are prioritizing the public safety and the health and well-being of the populace. So I think that just draws attention to the fact that these very good ideas are not designed to change, the basic identity of this country. These are measures that can be used to protect the basic fabric and stability of this country. Mm-hmm. What happens if we don't institute a universal basic income of some kind through federal relief? Small businesses will go under. They will be in 6 to 12 months, of course, unable to catch up on their payments in arrears and the deferred rents and leases. So the banks that lent to them are going to go under. Then you have the beginnings of a credit crisis on a broad level, and the federal government has to exercise a massive bailout with tax dollars or money that they take out of other budgeted line items in order to save the country. So when you zoom out and you take a step back and you see what enables our country to function as a stable society, it really hinges on the ability of people to pay their bills, the ability of people to borrow money and pay that money back with interest over the long term. When you disrupt that, you disrupt the ability of rich people to hold on to their wealth and poorer people to stay alive. That's a no-go. So I think we've got to call this what it is. We are moving into an era of universal basic income and universal free healthcare. We have to do it to preserve the social stability. We have to do it because otherwise, what we're looking at is not a gradual redistribution of wealth to save the working people of the United States. We're going to be looking at a forced or violent redistribution of wealth when there are major social disruptions that permanently alienate certain segments of our population. That's what I want richer Americans of means to recognize in these times, that to preserve the social stability of this country is to preserve your ability to pass your wealth down to your children and their grandchildren. If the poor working people who are vulnerable can't make it through this epidemic and keep their jobs and pay their bills, your wealth is going to evaporate within a generation. This is part of the social contract that we agreed to in this capitalist system. It's mostly worked, in my opinion, but it hinges on the ability of everyone to engage, to pay their taxes, to borrow money, and to pay that money back with interest. And it's ironic, but the measures we called socialist are probably the measures that we'll need to preserve that capitalism.
Your comment that the capitalist system has mostly worked for us is obviously up for debate.
Yeah.
And I disagree with that statement for the most part. But, just because we're married doesn't mean we have to agree on everything, right? So I think we have to stop there. It's 11 o'clock right now. So thank you, Dr. Kim, for chatting with all of us. And thanks to all of you for joining in on this conversation. We wish you well-being and health in mind, body, and spirit. And in terms of Agile Spring programming, obviously it's been postponed due to the pandemic. So our team is working very hard right now to provide virtual opportunities for important discussions like this and meaningful connection. You can stay updated by following us here on Facebook as well as Instagram. Also, if you are up for a free live streaming hip hop class, it's happening right now on Jasmine Raphael's website. She's a friend of Agile. And so I will drop in the comments the link you can go to for a free live streaming hip hop class. But thanks again for joining us, and we will see you soon. Bye.
Okay, bye. Thank you.